Okay, so I am Jordan Smith, and in coordination with my partner on the POCUS rotation, Jonathan Marks, we are going to present the Blue Protocol as we are both interested in going into critical care medicine. So the objectives for this talk will be to define the Blue Protocol, teach the basic strategy for performing the Blue Protocol, and understand the Blue Protocol algorithm, its branch points, and the associated ultrasound findings. So what does BLUE stand for? BLUE is an acronym. It stands for Bedside, Lung Ultrasound, and Emergencies. And essentially what the BLUE Protocol is an algorithmic way of ultrasounding critically ill patients who have acute respiratory distress for diagnostic and therapeutic purposes. Using the algorithm seen here, you can diagnose with about 90% accuracy 6 of the most common causes of acute respiratory distress. These include pulmonary edema, pulmonary emboli, pneumonia, COPD or asthma, and pneumothorax. And as you can see, and we'll talk about in the rest of the presentation, there are several pathways to diagnose pneumonia. And the other thing I like to mention is this was developed in Paris by Dr. Daniel Lenchinson. He was an intensivist. But then later on, there was a study out of Japan where they kind of compared the accuracy of the Blue Protocol with CT scans, and that's what it says down here, which we typically would think of as like the gold standard for diagnosing problems or diagnosing acute respiratory distress. And that's kind of, this study is kind of where they get this 90% accuracy number from. So when they developed, so just the tools you need to perform the Blue Protocol. When they initially developed this protocol, they used a 5 megahertz microconvex probe. So you'll see a lot of pictures from that in our presentation. But basically they used it the same way that we use our linear probe to obtain kind of longitudinal images of lung parenchyma between rib spaces. They used this probe in their studies because they thought it fit in between the rib spaces very nicely. And there's a part of the algorithm that asks you to kind of do a vascular exam, and it's very efficient for looking for DVTs and things when you do compression of the veins. So here we always use the linear probe, and we use it in a standardized way for lung exams and vascular exams, and it works essentially the same. So when you have a patient who's in acute respiratory distress and you choose to do the Blue exam, positioning can be your friend. So we try to, it's best to try to put the patient in a semi-recumbent position, which is essentially they would be supine. However, you would kind of elevate their back to a 45-degree angle. This will help you with things like the Plapp's point when you are looking for things like pleural effusion, because gravity is kind of your friend in those situations. Of course, though, if your patient is mechanically ventilated or has some kind of other like musculoskeletal defects that kind of prevent them from going in this position, having the patient supine is perfectly acceptable. So when you are performing the Blue Protocol, a lot of times it'll be important to find your artifacts in more than one lung zone. So typically having a finding in 3 lung zones is kind of a good way to say that you definitely have found a diagnosis. The lung zones are, you have zone 1, which you can kind of see is the anterior chest wall here. And then we have zone 2, which is kind of the axillary or lateral chest wall. And then the posterior chest wall is back here, it's zone 3. And then each zone is kind of, you can visually divide into 2 sections, kind of in half, to give you 6 total areas for investigation. You can use any of those 6 areas towards kind of your looking for those 3 different spots to find the same kind of artifacts. So we'll, at this point, kind of start going through the blue protocol. I'll go through part and then I'll pass it off to Jonathan. But the first thing you look for, especially in the upper and lower lung zones, is you have investigate for lung sliding. And so that's kind of the very top of our algorithm. And you'll say if it's present or abolished. And then there's this one profile here in the center, which we'll discuss, which it can be present or abolished. It doesn't really matter. But the main branch points that kind of lead down here and down here are looking for if that lung sliding is present or not. So lung sliding, and here typically we would use a linear probe and it would cover kind of the whole screen, but here this is that microconvex probe that we discussed earlier that they used in the initial studies. But lung sliding, when present, you can see a hyperechoic pleural line here under the subcutaneous tissue and kind of in between your rib shadows, right? And then this line, if this were a video, you would see that kind of moves rhythmically with respiration. Some people describe it as looking like ants on a log. And then, so you'll also have, in this picture, you can see these A lines, which are kind of hyperechoic. This one's not as prominent, but hyperechoic horizontal reverberations that are equidistant from the pleural line, and they're generated by subpleural air. And that subpleural air can be in the can be like in the alveoli, or it can be free air like in a pneumothorax. So just because you have A lines, it does not rule out a pneumothorax. But this lung sliding here is actually 95% sensitive with a 100% negative predictive value for pneumothorax. So while A lines don't necessarily rule out a pneumothorax, the lung sliding does essentially. And then lung parenchyma on a ultrasound will just kind of be a fuzzy picture because the air scatters the ultrasound waves. And then another thing you can do to evaluate lung sliding is look for M mode. And here you'll kind of see this standardized, like a stratified pattern above and below the very bright white pleural line here. This is known as like the seashore sign. And so let's see, that's pretty much everything about lung sliding. And so essentially when you're doing the algorithm, you assess whether lung sliding is present or not present, and that kind of takes you different ways. So once we've assessed that it's present, which we did in the last slide, we can kind of go through these A and B profiles, which are the next steps in our algorithm. So the first one is the B profile. And to understand the B profile, you have to understand B lines, which are, so here again we have the microconvex probe from that initial study. But B lines are basically these kind of well-defined hyperechoic, described sometimes as like comet tail, they're artifacts. And if you notice, they kind of erase the A lines. in the ultrasound. They're reflective of elements that have acoustic impedance gradients with the air within the lungs. So a great example is fluid. And if you have 3 or more of these in a single ultrasound view, although some people will say, this is where they kind of say that you need 3 views. But if you have 3 or more of these, it can be diagnostic of cardiogenic pulmonary edema. And it has a 97% sensitivity, 95% specificity, 87% positive predictive value, and 99% negative predictive value. And so if you look for this in, like I said, 3 different lung zones, and you find the B lines, that would be indicative of a B profile. And if you kind of go back, you would see that that would tell us a diagnosis of pulmonary edema. We would know that we need to diurese and treat accordingly. Okay, so then this is the point where Jonathan will kind of take over and present the rest.
All right. Thank you, Jorden. So just continuing on from there, we've seen basically the first branch point on the left side, or the lung sliding present with the B profiles. The next one we would look at. We go back real quick. Laser pointer. This one right here is one we're going to talk about next. Sorry, A profile right there. So we've already done, Jordan's done B profile right there. Now we're going to talk about A profile. So we see that there is normal lung sliding, and so we would see that right there. And then we would see the A lines, which are the reverberation artifact, equidistant from here to here. So we would see down there, and then if it went long enough, we'd see another one down there. And that means that we have at least well aerated lungs. So the question is, where do we go from there? So we have well aerated lungs. We've with the presence of sliding, we've ruled out pneumothorax. So the next thing that we are thinking of in this branch point is moving on to our venous analysis. And this is what Jorden was alluding to earlier with the vascular study that we would use that microconvex probe for. Again, nowadays in the ones we have, at least at our facility, we'd still use the vascular probe or the linear transducer. And we'd be looking basically for a DVT at this branch point right here. So we would be looking for, you could do the internal jugular subclavian, femoral, popliteal, IVC, and then the calf veins, basically just looking for the compressibility. If there's no compressibility, then we would be suspicious for a DVT. And if we found one, then we would be relatively certain that we were looking at a pulmonary embolism there. And that would be the reason that we would have lung sliding with well aerated lungs, but still dyspnea or acute respiratory failure. So that would be the A profile that we would be looking for in that branch point. I think I skipped a little bit ahead when I was talking about that, but just as a review, pulmonary embolism, we're looking for the DVT. And when we find that, we have a pretty decent positive predictive value and a great negative predictive value for pulmonary embolism. So if we don't find anything there in that DVT survey. And then the PLAPS point, so not to jump around too much, but if we're going back, just to keep everyone on the same page, we've come down here, we did our DVT analysis, and then we didn't see anything. Every vein was compressible as our survey went on. So now we've seen free veins. Now we're down to the last branch point really in this A profile side. And now we're looking at the PLAPS, which, let's see if I can, okay, great. So this stands for the posterior lateral alveolar and pleural syndrome point. That would be the zone 3 that Jorden was alluding to at the beginning of the presentation, where you move your probe over to this kind of posterior lateral section. And that's where we would see things such as consolidation, or we could see anechoic areas that would indicate maybe pleural fluid. And when we did that, if we saw those things, then we could move on to, so if we got a positive consolidation, we would say, okay, and now we're pretty certain this is pneumonia. If we didn't, then we've kind of, as far as looking at the 6 things that this study was designed for, we would kind of infer that it had to be some sort of other, like a lung disease such as COPD or asthma. So obstructive disease that would be causing this acute respiratory failure or dyspnea, but still have preserved lung sliding and no DVTs present. So again, it's important to remember that this study was designed to look at, the 6 most common things that comprise like 97% of acute respiratory failure diagnosis in critically ill patients. So that's not saying that that's all it could be, but likely it's one of these 2 things if we've excluded everything else in this pathway. All right, so that's just basically what this slide here says. We have a pretty good positive predictive value and negative predictive value, based again looking at those 6 diagnoses. And then so now we've looked at everything with lung sliding present. Well, let's visit the other side of the slide. And just as a interesting point, when I was reviewing this, most of these, like this side right here, will take up about 75% of the things that this study was designed to find. So most of your diagnosis will come from this side, but let's say the lung sliding is not present and we move into these B hash mark or A hash mark, A prime profiles. That's what this side of the chart was meant to kind of discuss. Basically, we've looked for lung sliding. There has been no lung sliding, and that's where we are. So, moving on. So pneumothorax, as you might recall, is down one of those lung points. So we'll be looking again at the A profile right there. These are the 2 signs that we'd be looking for, and I think Jorden discussed these a little earlier as well. So we have looked at the pleural line; it's not moving. We see that there are A lines, and then we've looked at the barcode sign. So when we've looked at the barcode sign, it doesn't show that, as we can see here. This would be more, this would be non-pneumothorax, and then skipping a little ahead, this would be the lung point. But we see the seashore sign, and then we see kind of the barcode sign right up here. So that is, again, this is an M mode using the special like curve, sort of semi-curvilinear probe. And this would be kind of suggestive of, at least suggestive of pneumothorax. And this is what you want to do once you found that and you're suspicious for pneumothorax, is it's important to find this lung point, and that's the point between like a well-sliding lung and then the non-sliding lung right there, because again, it's the sliding that kind of creates this fuzzy artifact there. So it's important to find this, and if you actually don't find this lung point in your survey, then you want to kind of move on to other modalities to assess for pneumothorax. But you want to look for this lung point to kind of solidify your suspicion that there's a pneumothorax here. So again, that would be the A prime kind of decision tree, which we can come back to real quick. A prime plus lung point. You have your diagnosis with a relatively good specificity for pneumothorax. Again, important to remember, if you don't find that lung point in your survey, don't throw away your diagnosis, but you'll need to use another modality to kind of confirm or deny that. Okay, moving on. And it's also interesting, I think Jorden mentioned it as well earlier, not to jump around so much, but if you look back, you see there's lots of different areas that pneumonia becomes part of the differential. And that's just kind of what this slide is kind of supposed to drive home. You can have like the A profile, the AB or C profile, and then abolish lung sliding and the B prime profile. And kind of move on, since we haven't talked about the AB profile yet. Basically, it just means that, and this can be possible with any, whether you have lung sliding present or abolished, on one side of the chest you found A lines, and the other side you found B lines. So one hemithorax has A lines, one hemithorax has B lines. So that's kind of this mixed profile. And with that, you would move on to pneumonia as one of your leading differentials. Moving on from there, the C profile, that basically just means that you've had this kind of consolidation right here. And again, can be referred to as many things, like some people call it tissue-like or shredded appearance. That sort of, along with having any, whether you have lung sliding, again, present or abolished, if you see this kind of shred sign or tissue-like appearance of consolidated lung, then you would think pneumonia. Again, in this population of critically ill patients where you're trying to exclude or include respiratory difficulty diagnoses. So again, the Blue protocol gives a pretty good overview of the, like I said, 6 most common, which in the study accounted for 97% of the diagnoses in patients that had acute respiratory failure. And the researchers that took part in the study were blinded, so they walked into a patient that they knew he or she had acute respiratory failure, but they had no insight into previous imaging or any laboratory findings. Even with that, just the diagnosis, just the chief complaint of acute respiratory failure, dyspnea, etc., they were about 90% accurate in the diagnosis of one of these 6 causes that they were looking for. So pretty powerful if you think about it. Again, with practice, takes less than 5 minutes, usually less than 3 minutes to go through the algorithm. A pretty powerful tool for a non-invasive study that is, sometimes the chest x-ray isn't always available, especially during the times with COVID. It was very being utilized all over the hospital, so the resources were pretty low. However, a lot of times the ultrasound is readily available. In fact, I've always been able to find one. So a very powerful tool in the arsenal, especially when resources are short. So again, during times of pandemic or low resource settings. And that's basically the Blue protocol. Thank you to Dr. Kapati and Dr. Valenzuela, and thank you very especially to my partner Jorden Smith in this presentation. Here are our resources, and we'd like to take any questions that you have.